Okay, so I'm going to be speaking today about determining viscosity of blenderized formula, and specifically also describing a novel approach to measure viscosity using the International Dysphagia Diet Standardization Initiative Framework, also known as the IDSI framework. So the objectives of today's talk are to describe benefits of using blenderized formula. I'll compare and contrast homemade and commercially available blenderized formula products, review administration guidelines when using blenderized formula, and discuss the unique viscosity characteristics of blenderized formula, and also how to measure using the IDSI framework. Blenderized formula has many aliases, but it really is simply defined as a formula made from pureed or blenderized foods, and it may or may not include the addition of commercial enteral formula, which is the standard enteral formula that we've been used to for many decades. And the unique ingredient of blenderized whole food makes this class of formulas different from standard enteral formulas that have been used in the past. And sometimes you'll see blenderized formula described as blended formula, blended diet, commercially prepared blended formula, pureed by G-tube, but these all really refer to the same thing, which is this food-based blend. Benefits of blenderized formula are that it provides whole foods as an enteral feeding, and it can significantly improve feeding tolerance by reducing gagging, retching, and vomiting, as well as improving constipation. It also improves transition to oral feeding when we have children that have averse feeding habits, and by just being fed this formula that's made from whole food, they burp and taste this formula, and it improves their transition to accepting oral feeds by mouth. And then it can also just reduce the need for medications, especially for reflux or constipation. The first study that really was a groundbreaking study that helped us feel a little more comfortable about using blenderized formula with patients was this paper that was written in 2011 by Scott Pentiek's group in Pittsburgh. And it really indicated benefits of blended formula. What they did was they looked at 33 children that were status post fundoplication, and all of these children were having challenges with gagging and retching and feeding difficulties. And they transitioned the children over a 3-year period to a pureed by G-tube diet. So it was a thick blenderized formula diet that was administered by syringe. And what they found was that more than half of the children reported a 76 to 100% decrease in gagging, 57% reported an increase in transition to oral feeds, 73% reported more than a 50% decrease in their GI symptoms, and no children's symptoms worsened. So this was really a big step forward, because prior to that, in 2011, a lot of families wanted to use blenderized formula, but a lot of practitioners and GI providers were not really that comfortable with just using this type of feeding as an enteral feeding instead of standard commercial formula. And then moving forward to 2019, Dr. Bridget Hron and Dr. Rachel Rosen from Boston Children's Hospital produced this paper, which really showed that there are significant improved health outcomes as well as quality of life for children and even young adults that are transitioned to a blenderized formula versus a conventional formula. And this was a prospective study that looked at 70 children age 1 to 19 and who were receiving either blenderized formula or conventional formula by feeding tube. And what they found was that there were decreased visits to the emergency room, as well as decreased admissions for hospitalization. The Likert scale that they used for their surveys showed that there was an improved quality of life with less nausea and vomiting, abdominal pain, diarrhea, and total GI symptoms. And overall, there was a significant increased patient satisfaction. So when we talk about blenderized formula, we can think first about homemade blenderized formula. And the benefits of homemade blenderized formula are that you can modify the ingredients to fit the specific needs of the child. So for example, specific food allergies or intolerances, even ethnic focused foods, so you can really tailor that blenderized formula to the family meal. And the feedings really allow for a normalization of meal times, and it's just like feeding another mouth, except it's going through a tube instead. there are criteria to consider for patients who want to try homemade blenderized formulas, and we need to make sure that the patient is medically stable. This is not going to be something that's initiated in the ICU. We want to make sure that we're able to clearly meet their calorie and protein needs from this blenderized formula recipe. The care providers have to be motivated because there's a lot involved in terms of preparing all of the blends and measuring and proper kitchen technique with food safety handling guidelines and storage and being able to follow recipes. And so it's really important that all of those are taken into account. And we also, as dietitians, want to make sure that we take into account nutritional considerations. So we want to make sure that we're assessing calorie and protein and fluid needs, as well as vitamin and mineral requirements. We want to pay attention to volume and what that child can tolerate for volume. And again, we want to really pay attention to encouraging food safety habits that are going to provide cleanliness in preparation and storage, as well as pay attention to safe hang times, temperature concerns, changes in viscosity of these formulas when they're frozen and then thawed, and then also even take into account transportation of this formula outside the home. So if the child, for example, is going to school, how is this formula, first of all, accepted at their school? Because, for example, schools in Massachusetts don't allow formula to be administered through a tube if it's in an unsealed package or container. So homemade blends cannot be provided to schools, and they need to have a commercial blend instead. And just even transporting to a hospital or a clinic visit. So all of those things need to be taken into account. Commercially prepared blenderized foods are now available, and these are really an excellent way to provide a simple solution for patients who want to try a blenderized formula, but they don't really have the ability or the time, or they just don't want to do all that food prep and blending and storage and cleanup. And commercial products that are now available are easier for travel, they're easier to administer at school, as well as being available in hospitals. They provide a consistent nutrient profile as well as viscosity, and they have a longer hang time as compared to homemade blends. Oops. And they can also be used in combination with homemade blended formula, or they can replace the homemade blends completely. The challenges with commercial products are that they can be more expensive out of pocket. Sometimes they're not covered by medical companies that are providing supplies or insurance. And also, if a child is just on one commercial product, they would be getting less dietary variety as compared to their homemade recipes. And we're always really encouraging variety. So we do encourage just, adding things to these homemade blends. Also, we want to also pay attention to the composition and that it may not meet a child's nutritional needs, adequately without supplementation of vitamins or minerals, or in some cases may exceed their needs. And then storage can be a little bit of a challenge just because the pouches are floppy and they're not that easy to fit in some just easily stack. So there are many available products now for commercial food-based blends. Some of the most popular ones are made by Real Food Blends, Functional Formularies, Nestle, Abbott, and then there are other formulas out there as well. Some are made by Medline, and then there are new products coming out often now. So this table I put together just compares some of the commercial products that are out there. And I'm going to just really pay attention to the key characteristics when we look at these. So Real Food Blends is the first group of food-based blends that are simple ingredients, 5 to 7 ingredients per pouch, and in general are about 240 mLs or 8 ounces per pouch, and come in different varieties. They have no added vitamins and minerals, and so that's something to take into account. When we look at Nourish and Liquid Hope, these are made by the Functional Formularies Company, and these are vegan blends of food-based blends, and are a little larger in volume than the Real Food Blends. about 310 to 320 mLs per pouch. And Liquid Hope does have almond in it, so you have to pay attention to a nut allergy in that case. Pediasure Harvest is the food-based blend made by Abbott. This comes in a container with a screw top lid and is going to contain vitamins and minerals and will meet the RDA for most vitamins and minerals with a volume of about a liter to 1200 mLs, and appropriate for age 1 to 13. There also is now an Ensure Harvest for older children and adults, very similar in composition. And then there's the Nestle products, which are complete organic blends. These come in 2 versions, for the pediatric and also the adult options. And these are hypoallergenic, and also supplemented with vitamins and minerals. And they come in a plant version as well as a chicken version. Looking at the comparison of these products with regards to thickness, Harvest, both Pediasure Harvest and Ensure Harvest, will be the thinnest of all of them, and is a slightly thick liquid. And you can see that Real Food Blends is really going to be the thickest, and is going to be almost the thickness of a puree in some of those versions. When we think about providing blended formula through a tube, in general, 14 French is generally recommended, although we do use 12 French G tubes and are able to administer food-based blends through that. NG tubes are in general too small in diameter to provide a food-based blend without significantly thinning it. And for J tube feeds, we really don't recommend homemade blenderized formula, although we do use some food-based commercial products and mix them with either Pedialyte or another thinner commercial standard formula to make sure that that flows well through the J-tube. And we also need to obviously pay attention to hang time with J-tube feeds, since they are administered through a pump over a longer time period. So how to administer is really, in general, pushing with a syringe, a 60 ml syringe by bolus. A pump can be used, and sometimes families modify their infinity pumps by snipping the little plastic tip, which is inside that blue rubber tubing. The hang times of these commercial products, again, range and are based on the manufacturer's guidelines. Food-based blends that are homemade, hang time is going to be 2 hours or less. Real Food Blends also recommends 2 hours or less. And then the other products go up to 8 to 12 hours. When you add additional water to any type of formula, though, that reduces the hang time to 4 hours. And that is based on Aspen guidelines. Typically, as I said before, 60 ml syringes are used to administer these feedings. This picture just shows standard 60 ml syringes, which have the O-ring that's more of a rubber material, and that really gets difficult to push after a short amount of time using food-based blends. And kind of a comic relief here that you really almost need like a caulk gun to push that syringe. And so what we found is that the silicone O-ring syringes work much better and don't get stuck. And one brand is the Miracle syringe. Squirrel Store also sells these squirrel syringes that have this silicone O-ring that makes it much easier to push these food-based blends. So just moving towards talking a little about viscosity of blenderized formula. We know that blenderized formula viscosity can vary significantly, and the viscosity can change. The viscosity changes can impact GI tolerance as well as the administration of feeds. So we know that with these thicker feedings, children have less reflux and less retching, but if it's so thick, it's very difficult to administer. And so we find that there are ways to alter that by either adding additional liquid or even modifying the blend by freezing it and thawing it can also make it thinner in most cases. And the method used to add additional liquid to a commercial product can also result in variations in viscosity, and I'll talk a little more about that. So when we're talking about measuring viscosity in formulas and in liquids in general, we can use a viscometer to measure viscosity. But a viscometer is a very expensive tool, and in general can run thousands of dollars. And it's also not quite ideal for measuring the viscosity of food-based blends because food-based blends are non-Newtonian liquids. And so they're really a mix of food. They're not a consistent solution. And so when you have that viscometer spindle spinning in that microenvironment, it's not really measuring the viscosity of the entire container. And so what we found is there's a very simple way to measure the viscosity of formula, and that is using the IDSI test. And IDSI, again, stands for International Dysphagia Diet Standardization Initiative. And this is a framework of definitions that describes the measurement of a liquid thickness in an objective way. And so, so you take a 10 ml syringe and you pull out the plunger, you put your finger on the bottom of it, you fill it up with 10 mLs of liquid, you let off your finger and let the liquid flow out for exactly 10 seconds and then restop it. And whatever liquid is left in that syringe, you use this chart, and that will tell you the level of thickness of that liquid. So for example, if less than 1 ml is left in that syringe, then that would be a thin liquid. Slightly thick would be a 4 to 8 ml remaining liquid in that syringe. And then 4 to 8 would be mildly thick, moderately thick would be 8 to 10. And then if nothing comes out, that is an extremely thick liquid, and that would be a 10 plus. And you could also then use a fork drip or spoon tilt test for that thick puree type of blend. So the paper that we first published and this was in JPEN, was describing the use of this IDSI test to determine the viscosity of different commercial blends that were available on the market at that time. And so what we found was, first of all, we used a reference formula, which was old complete pediatric 1.0. This has been a formula that's been on the market for probably almost 30 years. It does include food, but it's from a source of purees and mostly powders that are reliquefied. So it's not completely the same as a blenderized formula that is a food-based blend. We know that complete pediatric 1.0 runs through enteral feeding pumps fine without further dilution. And when we measured the IDSI value of complete pediatric 1.0, it came out to a 1.8, which is a slightly thick liquid, being in that range between 1 and 4 mLs. We then tested the viscosity using the IDSI test of all of these other blends. And what you can see is they ranged from a slightly thick liquid all the way to a very thick, almost puree. And then what we did next was figure out how much water did we need to add to these products when we stirred that water in to get that viscosity to a slightly thick liquid so that it would run easily through a pump. And you can see here the amount of water ranged from 0 mLs for Pediasure Harvest up to 270 mLs for some of the real food one of the real food blend products. And the pouch itself was 240 mLs, so we had to add more water than what was in that pouch to get that thick blend to a slightly thick liquid. Another study that was done at Boston Children's that also looked at just adding water to these commercial blends and what happens with clinical occurrences really with these children is Suzanne Hirsch and her team looked at the impact of patients receiving blenderized feedings and more than 20% of their diet was thin liquids. And so in the black bars here, you can see that children that received more thin liquids had more emergency room visits, required more chest x-rays due to aspiration concerns, and had some abnormal chemistries with regards to mostly specific gravity of their urine. So the findings of this paper also showed that there really was a wide range of water that was added to Blenderized formula by families, and there really were no guidelines yet to tell them how much water they should be adding. And in the most recent paper that I just had published, we also just compared what happens when you look at different mixing methods. And so what we found was that you can add water to these commercial products by either stirring it in, or you can add water and then put it in a shaker cup with a whisker ball and shake it for 60 seconds. Or you can add water and put it in a blender and blend it for 60 seconds. And what we found was that especially the formulas that required more than 30% additional water and didn't have additional vitamins or minerals added to them got significantly thinner when you put it in a blender as compared to stirring or shaking it. And so that's a concern because we want to make sure that we're still providing a thick enough formula to take advantage of those clinical benefits, but also thin enough that we can administer it. And so I think that future studies really need to look at what exactly is that optimal viscosity level to achieve those clinical benefits that can still be practical for administration of these blends. And I've just included my references here, and then I will open it up to questions and answers.